Hi, we're group 7, and we're doing our case study on David. David is a 65-year-old male. About 6 weeks ago, he's been noticing severe cramps in his lower left quadrant, most noticeably about 1 hour after his meals. This is right above like the descending colon and some of the small intestine. On top of this, he's noticed that he's become a lot more fatigued, and he's also lost 12 pounds in this time span. And upon examination of his stools, he's noticed that his feces have become a lot smaller in diameter, and that he found bright red blood in his feces. So with the fatigue and the weight loss, those could stem from a lot of small, minor problems. But when you combine it with the blood found in his stools, and we have a problem, he needs to go see a physician. It's most presumably going to be colon cancer. So upon seeing his physician, the physician's first step is to do a palpation of the stomach, because with the blood in the stools, we're going to check out the colon first. So with the palpation, which again is using sense of touch to feel the affected areas, he finds in the lower left quadrant that David has a lump growing right above the descending colon. Also, he checks in the upper right quadrant right above the liver and feels that David's liver is enlarged and a little tender, hurts to the touch. So that's a condition called hepatomegaly, which is just a enlarged liver. And so from this point, David's physician sends David to a specialist to have what's called a air contrast barium enema performed.
So the air contrast barium enema, as Joe mentioned, is going to need to be done to David next. And what this entitles is a tube getting stuck up David into his large intestine. And what the air contrast barium enema is there's a barium water mix, and the tube secretes this, and this basically just lines the large intestine. And after this lines the large intestine, air is pumped into the large intestine to expand it. And what this allows for is a clear x-ray of the large intestine. So here we can see an x-ray of an air contrast barium enema. And as you can see, the large intestine is completely outlined. And this is because of that barium water mix that is lining the large intestine. In a normal x-ray, the high frequency waves would normally just go through the tissues of the large intestine. As you can see, the small intestine is not shown here. That is because of that same reason. But because of the barium, the large intestine is able to stand out. And also what you can see from this picture is how the large intestine seems enlarged, how it seems bigger than it normally would be. And this is because of the air that is pumped in. And this air and these enlarged large intestines allow us to see if there are any clusters or clumps of masses of tissue that aren't supposed to be there. If it was not enlarged and it was just regular and normal size, the masses might just be tissue that are there from normal lumps. So in David's case, we were able to see a polyp in his distal sigmoid colon. And this doesn't mean he has cancer yet, but it could mean that. And also in his proximal sigmoid colon, we were able to see lesions. And so the primary diagnosis for David is going to be colon cancer, but we cannot find that out through this. We have to go to something else. But before that, we will mention the differential diagnosis, which could be ischemial colonitis. And this is inflammation in the colon, which could cause something looking kind of like this polyp here or lesions to appear. So to make sure that it is the colon cancer, we will do a flexible sigmoidoscopy. Now what this is it gives David the opportunity for the second time in a couple days to get a tube shoved up into his large intestine. And as you can see here, the doctor puts this tube up, and at the end of this tube is a little camera and a little tool right next to it. And that camera allows us to see what we're looking at inside of the large intestine. And that camera, or the tool, is there to get cuts in little pieces of the areas that we want. So the areas that we're focusing on for this flexible sigmoidoscopy are the proximal sigmoid colon with the lesions and the distal sigmoid colon with the polyp to see if those are cancerous or not, or in which type of cancer. And the results of the flexible sigmoidoscopy will be discussed with G.
Alright, so after performing the flexible sigmoidoscopy on David and getting back the biopsy results, we were able to tell that the developing polyp in David's distal portion of the sigmoid colon is actually adenoma, and adenoma is actually an enlarged but benign growth of glandular cells. And benign basically means that it isn't harmful, but if it's left untreated, it could be cancerous. And also, we were able to find out that the lesions in David's proximal part of the sigmoid colon is actually carcinoma. And carcinoma is basically cancer derived specifically from epithelial tissues. And it is malignant, basically meaning that it is infectious. And also, 90% of cancer actually is derived from carcinoma. And the reason for that is because we have more epithelial tissue in our body than glandular cells, which therefore increases the chances of getting cancer due to carcinoma. After doing the flexible sigmoidoscopy, we were able to tell that David unfortunately has colon cancer in his sigmoid colon, and which has already begun to metastasize around his body, but specifically more in his liver. David does have stage 4 cancer, which has significantly reduced his chances of survival, but it isn't terminal. He still does have options for treatment, like surgery, sigmoid colectomy, which is basically the removal of the whole of the sigmoid colon, and then after that we do have treatment like chemotherapy. So over here is just a quick comparison of adenoma and carcinoma, and I would say one of the biggest things that you could tell them apart from is that over here in the epithelial tissue, it is lined with epithelium, and that there is evasion of blood vessel right here, as you guys can see, this white part. And I would say that is definitely the most important part of telling them apart.
Okay, let's summarize the system that David is experiencing and why they are occurring. So let's address the reduced amount of bowling sounds and also the smaller caliber stools and the abdominal cramps that he's experiencing. This is due to the pressure buildup in the sigmoid colon and also the 100% blockage of the proximal sigmoid colon, where the cancellous cells are growing, and which causes narrowing of the sigmoid colon. Also, next we want to address the decreased appetite. This is the way of the brain figuring out that there's something wrong with the GI tract, and it's trying to clear out the GI tract. Also, they're experiencing weight loss, and this is due to the significant blood loss that he's experiencing, and also due to the cancer cells using the energy from the David calorie intake. And also, lastly, we want to address the iron deficiency anemia that David is experiencing. This means that it's a reduced amount of iron that attaches to the blood cells, and also this is due to the blood loss that David is experiencing, and also this reduces the oxygen carrying capacity of the hemoglobin. Lastly, we want to address the hepatomegaly, which is an enlarged liver that David has. We feel that David colon cancer has metastasized through the hepatic portal vein to the liver. So the sigmoid colectomy surgery will address the colon cancer, which will by removing the cancerous part of the sigmoid colon, but it will not address the metastasis of the liver. Also, we want to remove any lymph nodes, mainly in the mesenteric area, where they may be cancerous, so they don't metastasize to other parts of the organ or other parts of the body. And lastly, to treat liver metastasis, we want to do hepatic artery infusion, which is like a pump or a catheter that's placed in the hepatic artery, which will infuse chemotherapy drugs directly to the liver, and hopefully reduce his cancer and increase his